Thanks everyone for joining us at Grand Rounds. As you're hopefully all aware, at SHN we have the distinction of founding the first division of clinical pharmacology in a Canadian community hospital. And our division offers a consultation service that supports all three of our clinical sites. And we're available for consultations regarding drug reactions, drug interactions, drug desensitization, addictions medicine, and toxicology. For those who have not trained in Toronto and maybe haven't been exposed to clinical pharmacology, we thought this might be an opportunity to increase awareness of our services and give you all an idea of what kind of cases we might be able to assist with. So we thought we might present a few interesting cases from the University of Toronto's postgraduate training program in clinical pharmacology and toxicology. So today we have with us three of the fellows from that training program who will be presenting some interesting cases and leading the discussion. And I'll pass things over to Dr. Miriam Nadeau to start with the first case.
Great, I will just share my screen. Do you see my full screen?
Yes.
Good. So hi everyone, my name is Miriam Nadeau. I'm a first year fellow in Clean Pharm and Toxicology, and I have an emergency medicine background at IELTS. The presentation that I will do today, it's about plasmapheresis in acetaminophen overdose. Are you perplexed? So first of all, I have no conflict of interest. And the aim of my presentation will be to review the role of plasmapheresis in the treatment of acute liver failure associated with acetaminophen overdose. So first of all, we'll review an acetaminophen overdose case with poor prognostic. And after that, we will go to review the evidence of PLEX. Is there any place in acetaminophen overdose? Is there any associated complication? And if we use it, which dose should we choose? So here's the case. It was a 41-year-old female that we don't know exactly the hour of egestion, was probably around 14 to 20 hours ago. She took acetaminophen 195 grams with duloxetine 2,580 milligrams, olanzapine 300 milligrams, and ibuprofen 10 grams. When she arrived at the ED, she has a level of consciousness that was altered. She was vomiting. She was really hypoxemic despite 100% of FiO2 at 80%. And she showed some anticholinergic symptoms as urinary retention. Quickly, she has been intubated, and quickly she shown a profound vasoplegic shock. She needs 3 vasopressors, norepinephrine, epinephrine, and vasopressin at really high dose to try to keep quite okay blood pressure. So the first lab that we received was a metabolism at 11.9% with an APAP around 5,000, ALT at 243, RNR at 1.6, creatinine of 124, metabolic acidosis with a pH of 7.08 with a Burkarb of 7, and a lactate of 11.6. The first recommendation that we gave to the bedside team was one, put an NG tube and try 1 dose of activate charcoal, even if it was a long delay, just to try to help more as we can the patient. However, the bedside team feel that the delay was too long, so they didn't do it. And we also recommend some methylene blue. In fact, one of our hypotheses for the presence of methemoglobinemia in this case was related to the massive overdose of acetaminophen. There are some case report of people who did massive overdose that present with some methemoglobinemia. So the first dose that we gave was for our methemoglobinemia that was around 11%, but also because she was really hypoxemic, even when we give her oxygen. With the first dose of methylene blue, she responded really well. Our oxygen increased at 95%. And the second dose was more giving because of her deep vasoplesic shock, so try to help for the blood pressure. After that, she didn't receive any more methylene blue because our symptom was better for the hypoxemic part, and the methemoglobinemia didn't increase again. We also recommend to start the NAC infusion protocol. Here, because the patient shown a lot of high-risk feature, we recommend the high-risk protocol. This means that it's the same bolus for everyone, 60 milligrams per kilo per hour for 4 hours. And then usually you will start an infusion of 6 milligrams per kilo per hour, but here we recommend the 12 milligrams per kilo per hour. We also recommend 1 dose of famotidine for the Tylenol overdose, and we also recommend directly to start dialysis. Here, the best recommendation was to start the intermittent hemodialysis, but because the patient was too unstable, she has been put on the CRRT. At the meantime, when she has been started on CRRT, we adjust the famotidine dose for 10 milligrams per kilo every 4 hours during the time that she is on the dialysis. She also received some amps of D50 for hypoglycemia, and the bicarb infusion has been started again at the same time. So here is the trend of her lab during the time that she has been hospitalized. The time 0 is not the time of ingestion because, as I said earlier, we didn't know exactly the time of ingestion, so it was easier to me to show you the trend if time 0 was the first time that we got labs. So you can consider that time 0, it's mean 14 to 20 hours post-ingestion. So the first thing I want you to notice, it's the really slow decrease of the Tylenol over time. We were expecting that the Tylenol would decrease faster than that usually, but we can see that at time 33 hours, she still have a high level of APAP in her blood. Also, the second line, the ALT, we can see that with the time she developed some acute liver injury. And one thing that is interesting is the trend of the lactate. We can see that she had a really high level of lactate, and one hypothesis was that maybe epinephrine was contributing for our high level of lactate. So at time 13, our epinephrine has been changed for phenylephrine, and what is interesting is that after that, our lactate decreased at half, and when they need again to put epinephrine because our vasopressor shock was worsening, the lactate levels increase again. At time 30, she needed 4 vasopressor at a high dose and 2 doses of hydroxycopolamine to try to treat her deep vasopressor shock that she was presenting. And to complicate the picture of this case, the patient also developed a serotonergic syndrome around the time 14. She had clonus, hyperreflexia, and started to be hyperthermic. The maximum temperature that she presented was 39 degrees. At this time, our hypothesis was there's many causes for serotonergic syndrome. She took a big amount of duloxetine. She received 2 doses of methylene blue, and she was sedated with ketamine and fentanyl. So our recommendation was to change our sedation for Versed and hydromorphone, to stop, don't give any more methylene blue if needed, and to try to cool the patient. Quickly, she responded really well with the benzo. Our temperature never increased again, and I can say that the serotonergic syndrome was quite well controlled after that, was not the big issue here anymore. And the last thing that I want to show on this slide is that around time 22, the liver transplant team have also been consulted, but because the patient didn't meet all of the criteria for the King College criteria for the liver transplant, they just said that they will follow the case, and when she will meet it, they will consider it if she's a candidate or not for the liver transplant. However, after that, when she met the criteria, she was too unstable to be able to be transferred. So that was one issue that we encountered in the case. So here I just put again the King's College criteria to just remember us what it means. So it's mean when we meet King's College criteria, it means that the prognostic of survival without liver transplantation is around 25 to 40%. You should have one of the 2 criteria. The first one is to get a pH below 7.3 or lactate above 3.0 after fluid resuscitation, or to get all of the next criteria, a creatinine above 300 micromole per liter, INR over 6.5, and a grade 3 or 4 of encephalopathy. So here, our patient meets at one point the liver transplant criteria, but unfortunately, she was too unstable. So the next question that we had with the bedside team is that, can we consider plasmapheresis in this case? Can we consider it before liver transplantation, or if there's any contraindication to transplantation? So here I want, So why we wanted to consider plasmapheresis? There's some proof that plasmapheresis can decrease the severity of hepatic encephalopathy, can help to decrease the vasopressor recruitment, and can help to accelerate the hepatic nitrogen turnover. The mechanism of action is, first of all, to remove the plasma stoichine, adhesion molecule, toxin, and metabolite in the blood. They can help also to replace some plasma factors and have an action on the immune modulation also. So here, I want to show you, there's some systemic review that have been done in the last few years. This is the most recent one that we have that have been published in 2024. And as what we can see is that overall, they seem to have some proof that plasmapheresis can be in favor for increasing the overall survival of patients. This was the survival of patients at 60 days post-admissions. And in all of the literature, there are just two RCT that have been done, the Larsen and the Maywell. The Larsen is the one that I will talk a little bit more because it's the only RCT that we have that include a significant amount of Tylenol etiology, so that we can consider for our case here of people who have intoxication with Tylenol. And the last thing that I want you to show, that's really interesting because all of the systemic review that I'm looking for, they always have a low heterogeneity. Here it's 12%, and I have another that was 0%. So all of the studies go quite in the same way. So what is the Larsen study? So it's been published in 2016. It was an RCT that have been done over 12 years and was include all acute liver failure presentation with at least a grade 2 hepatic encephalopathy and include all etiology except alcoholic hepatitis, hypoxic hepatitis, known chronic liver disease, malignancy, and liver graft. And they were compared patients that got the standard medical therapy for acute liver failure with patients that received this standard medical therapy plus a high volume plasma exchange. The table that you see, it's the table 1 in the study that showed the clinical characteristic of both groups. First thing I want you to notice is that the number in yellow, it's the proportion of people who took Tylenol as the etiology of their acute liver failure. So it was over 50% for each groups. So the reason that this study is the gold standard right now to consider plasmapheresis for Tylenol overdose. I also want you to notice that patient was quite ill. More than half of patients in both groups have an encephalopathy of grade 4 and grade 4 encephalopathy, and around 60% of both groups need vasopressor. So patient was quite sick in both groups. So here is the result of the study. On the left, you can see the overall survival at the day of discharge, and it was statistically significant for patients who received plasmapheresis. The difference was 58% of survival in the plasmapheresis groups versus 48% for the standard medical treatments. And on the right side, we can see if we're looking more in subgroups of patients with who seem to get more benefit of plasmapheresis. If we look to the patient who received a liver transplant, there was no difference in the overall survival. But if we are looking in the groups that got any contraindication to liver transplant, so they were meeting poor prognostic criteria with King's College criteria, but they had contraindication, medical contraindication or psychiatric contraindication for the liver transplant, and there was a difference that was statistically significant between the groups that received plasmapheresis versus they didn't receive the plasmapheresis for the survival. Other result that shown benefits for plasmapheresis was that the groups who received plasmapheresis showed a decrease of INR, bilirubin, ALT, ammonia. The need of renal replacement was lower in the group of plasmapheresis. There was an increase of their MAP and a decrease in their vasopressor need. Their sulfa and CIS score was improving as well, also, and our pro-inflammatory markers were also decreasing. The incidence of adverse event in both groups was similar, except that there was a decrease in the platelets in the plasmapheresis group, was the only adverse event that I noticed in this study. So the conclusion of this study is that plasmapheresis, high volume plasmapheresis, appear to increase the survival in patients with poor prognostic criteria, but contraindication for liver transplantation. So the next question is, perfect, we can consider plasmapheresis maybe for a patient that have overdose with acetaminophen, but is there a complication that we should consider first? If we're looking to the two RCT that exist in the literature, they do not seem to have a lot of adverse events, except for the thrombocytopenia. However, there's a many complications that have been reported in the literature. There's the classic catheter-associated complication, hypotension, bacteremia, thrombocytopenia, hemolysis, citrate accumulation with hypocalcemia, metabolic alkalosis, inadvertent drug clearance, anaphylactic and allergic rash, respiratory distress, and tachycardia. The next question is which dose of plasmapheresis we should recommend for this kind of patient. Currently, because of the Larsen study, that is the best that we have for Tylenol overdose, currently a lot of groups recommend high dose plasmapheresis. But why to consider standard dose and low dose? It's that there's some evidence that standard dose and low dose can also be benefits for this for a patient with acute liver failure. And it can be interesting to reduce our plasmapheresis dose to help to reduce the risk of complication like hypocalcemia and volume overload. On my next slide, it's the same systemic review that I presented you earlier that compare patients who receive plasmapheresis versus standard medical treatment. But here, they did the separation in patients in study that use high volume plasmapheresis, standard volume plasmapheresis, and low volume plasmapheresis. So as you can see, there's still some sign that plasmapheresis can be helpful even if you're using a smaller dose of plasmapheresis. And here I just show you where is the two RCT goes in the groups. So if we are going back to our case, our patient was really unstable and we had already maximized a lot of therapies and she was not a candidate for transplantation. So at this time, we feel that she can be a candidate to try low-dose plasmapheresis. We didn't want to try the high dose because we just feel that this patient was too unstable to tolerate. However, we were not able to try it because the patient was not in a PLEX center and she was too unstable to be able to be transferred. So we recommend to maximize all of the support treatment, so to increase the infusion of NAC, to increase the CRRT rate, to increase again the vasopressor, even if there was already at a high dose, and continue famotidine. But unfortunately, she died the next night. So my conclusion of this case is that first, plasma exchange should be considered when a patient meets King's College criteria, but as a contraindication to liver transplantation. And I would say that we should not wait to reach the King's College criteria before considering to transfer a patient, because often we will miss the opportunity to be able to transfer before the patient starts to be too unstable. It is unclear if there is any benefit for patients that are going to have a liver transplantation. And a question that is still unanswered is that, is there any benefit to use plasmapheresis before meeting King's College criteria and thus reduce the number of liver transplants? So this is the end of my case. I would like to thank you everyone that have been involved in this case, and a special thank you to Dr. Montainton who share me a lot of good papers and some protocols that are done in Quebec, where there's a more plasmapheresis that are ongoing right now. So I have my email if you have any question, and yeah.
Okay. Okay, thanks very much, Miriam, and we'll take some questions. I see Vince has his hand up already.
Oh, sorry, I had a hard time coming off of mute. Thank you, Miriam, for the very interesting case, because again, we're often sort of put in the situation where I find that when we're instructed from the transplant team, patient doesn't meet the criteria, thank you, we'll follow along. Oftentimes that's sort of a kind way of saying best of luck. In terms of, I guess the question that I had was with regards to the, I guess the data supporting plasma exchange. Did the data suggest that patients did better with Plex as a bridge towards then liver transplant? Because again, to me, it looked like the curve separated and that there was differences in those who had Plex and then a liver transplant. And if that's the case, then yeah, should Plex be viewed as a bridge in conjunction with transplant team on board?
It's a good question. Right now, the study doesn't show that there's benefits if patient will get the liver transplant. The data for now show more benefits if patient have contraindication and won't get the liver transplant. However, the point that I don't know, and there's nothing in the literature, is if we use plasmapheresis really earlier, can we maybe avoid one liver transplant that the patient will be a candidate in the future? But for your questions, right now, the literature more say that the benefit is more when patient won't get the liver transplant because the overall survival is quite similar in the groups that got the liver transplant.
Thank you.
Yeah, I think the big challenge with this therapy is similar to liver transplantation is lack of access, right? The liver transplantation team is essentially all down at Toronto General and obviously has limited resources. Unfortunately, the plasmapheresis unit is also at UHN and some plasmapheresis at St. Michael's Hospital. But, so again, the issues about transportation and access to the therapy are going to be limiting in terms of its implementation, I think. But still very useful, particularly for patients who have contraindications to liver transplant or maybe not the best candidate, maybe a temporizing measure or maybe may alleviate some of the need for transplantation.
But to go also for the comment that Dr. Tien gave, I agree that I feel that this kind of patients should be transferred even if we are not sure they will meet the liver transplant criteria because they have also the resource to give plasmapheresis and other treatments. So maybe it's my own opinion, but maybe we should be able to transfer them even if they won't get the liver transplant at the end when we feel that we're going in this way anyway.
All right. Any other comments or questions? Doesn't look like it. So thanks, Miriam. And we'll move on to our second case then with Dr. Carolyn Tan.
Chris, is it okay if I go next?
Oh, yeah, of course, of course. So Dr. Jessica Kent will be presenting our second case instead.
All right, surprise. I met many of you on my elective 2 months ago. Let me just get myself situated here. All right, does everything look okay?
Yes.
Amazing. Okay, so unlike Miriam's case, which was very complicated and but also very interesting, my case is relatively straightforward and but hopefully just as interesting. So the title of my presentation is The Harms of Powdered Milk, a case of barium carbonate toxicity. As many of you know, I am one of the PGY5 eMERGE residents, soon to be staff at St. Mike's. Concurrently doing my toxicology fellowship, Miriam, Carolyn, and I are all in the same year. Okay, so the case. This is a 22-year-old male who presented to a community emergency department with a chief complaint of weakness, as well as nausea, vomiting, and diarrhea. So the emerge doc goes to see the patient, and when he sees the patient, he gets more of the story. The story is he's a previously healthy international student. The student was up at night wanting a glass of powdered milk, as any 22-year-old would. He poured two heaping tablespoons of the powder in a glass and drank it down, and unfortunately experienced a burning sensation in his throat right away. When he looked down at what he'd actually consumed, he realized it was barium carbonate. This barium carbonate had been purchased many months ago by mistake. He'd actually meant to purchase sodium bicarbonate, which is also known as baking soda. He got the barium carbonate, recognized the mistake. Rather than throwing it out, he put the barium carbonate in his baking cabinet along with where his baking soda would be and the powdered milk. And then 6 months later, forgot about it. In the middle of the night, he goes to get the powdered milk, grabs the barium carbonate by mistake. Seemingly unbelievable, but true. So back to the emerge. Over the course of a few hours, he develops the symptoms we already discussed, but moreover, he starts becoming profoundly weak. The emerge doc gave him IV fluids, some antiemetics, and then Ontario Poison was called for more advice. And by the time that I spoke with the emerge doc, they got a bit more information. One was that they confirmed that yes, indeed, this was a barium carbonate overdose, which is a common rat poison. As well, they confirmed that the potassium of this patient was 2.1 and the CK was unmeasurable. Unfortunately, this community hospital's CK cutoff was greater than 6,000. So it could have been 6,001, could have been 160,000. So before we get into the management, let's just do a quick general overview of what barium carbonate poisoning is, because it's it's super interesting, at least to me, and it's certainly very rare. So barium carbonate is typically found in ceramic glazes, but as I also mentioned, it's also used as a rodenticide. Exposures are usually intentional. However, there are some accidental reports, and these are all usually in the context of mistaking the white powder for something like flour, and in this case, powdered milk. So what are the toxicokinetics of barium? Well, toxicity results from as little as 200 milligrams of barium salt, with lethal doses reported of as little as 1 gram. Our patient ingested 11 grams. It's quick acting. It takes 2 hours before it reaches peak serum concentration. It's rapidly redistributed into the tissues, followed by a slow decrease in serum barium concentration, and a half-life of about 18 to 85 hours. And it's renally cleared. So how does barium carbonate cause problems? Well, what it does is it causes hypokalemia. And the mechanisms of toxicity from barium carbonate include antagonism of inward potassium rectifier channels and an increase in sodium potassium ATPase activity. These combined effects increase the intercellular potassium concentration and result in hypokalemia. And what are the clinical manifestations? Well, unsurprisingly, many of these are also associated with profound hypokalemia. GI symptoms, headache, paresthesias, muscle weakness, paralysis, QTc prolongations, dysrhythmias, and rhabdomyolysis. So what did we say to do? Well, of course, you call the poison center. No call would be complete without a recommendation for supportive care. We also recommended judicious potassium replacement. Another kind of cool treatment for barium carbonate toxicity is the treatment of oral magnesium sulfate. And this is actually for the purposes of GI decontamination. So for a barium carbonate overdose, you do not recommend oral activated charcoal to decrease absorption. You recommend oral magnesium sulfate. And how this works is very cool. So basically, the barium goes in the stomach, makes barium chloride, and if you give oral magnesium sulfate, the magnesium sulfate will bind to the barium chloride and make barium sulfate. Barium sulfate is what you use for a barium swallow. As we know, patients who have barium swallows do not die and do not become barium toxic. That's because barium sulfate is insoluble and is easily excreted by the body without any issue. Of course, you give the mag sulfate orally because, again, it's to limit the absorption. It's not an antidote. If you give it IV, it'll precipitate the barium in the renal tubules, and the patient will develop profound renal failure. So that's a side tangent. We also recommended dialysis. So for the rest of, my short talk, I'm going to talk about the utility of dialysis for barium carbonate, specifically its role in weakness. So again, we talked about this clinical manifestations, pretty much all in keeping with hypokalemia. So one would surmise that if hypokalemia is the only problem here, correcting the potassium should resolve the weakness. But this is actually not shown to be the case. There are many case reports, starting with this first one published in 1984, where patients come, they've been poisoned with barium carbonate, they are hypokalemic and weak. They treat the hypokalemia, potassium comes within normal limits. However, the weakness persists and actually worsens, and many of these patients develop a flaccid paralysis requiring intubation and mechanical ventilation. As we can see in this relatively confusing graph, as plasma potassium levels at the bottom rise, muscle power goes down. What is interesting here is that there's another little line below muscle power, and that's the barium levels. So as you can see, the mechanical ventilation need and the weakness is associated with barium levels, not potassium. So this was seen in many, 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 many more case reports since then. And the conclusion is that the weakness of a barium carbonate overdose is correlated with serum barium levels and not serum potassium. So why does this nuance matter? Well, of course, hypokalemia is a problem, and if not treated, the patient will die. But hypokalemia is not the only problem here. It's not what's fully responsible for the profound weakness and paralysis which necessitates mechanical ventilation. The weakness is multifactorial. Therefore, the treatment is more than just potassium replacement. So if we go back to the case, the patient's now admitted up to the ICU, a central line's inserted with aggressive potassium replacement ongoing. The potassium is improving with this approach. It was 2.1, then 2.3, and now it's 4. However, as we see as would be unsurprising based on the case report evidence, the weakness is not improving, if not getting a little bit worse, despite the potassium now being within normal limits. The resident is calling, asking for more information about how dialysis might be helpful. So anytime we're faced with a question in toxicology about when dialysis might be helpful, we go to X-Trip. Unfortunately, X-Trip is great for common poisonings and overdoses. This is not one of those cases. So what we had to do is actually do a literature review to determine what were possible indications for dialysis in this patient. So, by the way, barium is readily dialysable, but doesn't improve outcomes. So for patients who did not receive dialysis, really there's this case report in 1984 that I've already talked about briefly. That's a great example of what happens when when dialysis is not used to treat. So what happened here is that the patient was hypokalemic and the weakness persisted despite potassium correction. They were intubated for almost 4 days. Again, while the potassium is within normal limits, and the spontaneous breathing did not return until day 3. However, due to weakness, even after they were extubated on day 4, they were still super weak, and they were in the ICU for 6 days, with weakness persisting greater than 7 days. Now, when we look at case reports where dialysis was used, while the cases are heterogeneous due to the fact that a lot of the times it's not readily apparent that the person did take an overdose of barium carbonate, what's interesting about all the published cases in the literature, caveat being publication bias, but anyways, is that as soon as the barium carbonate poisoning is recognized and as soon as dialysis is initiated, the weakness improves pretty much right away, within like an hour. And all of the patients were extubated within 24 hours of having received dialysis, and most within a few hours of receiving dialysis. And these patients varied from, they recognized the barium carbonate poisoning right away on the first day to 3 days later. But again, all were associated with rapid correction of weakness, serum barium levels, and associated with extubation. So again, the bottom line here is that severe barium carbonate toxicity results in prolonged hypokalemia and flaccid paralysis. And due to the fact that it takes a long time to clear barium, results in severe poisoning for days. Dialysis, irrespective of the type of dialysis, is associated with clinically significant increase in barium ion elimination. It rapidly stabilizes the serum potassium level, and it rapidly restores motor strength in as little as 2 hours, facilitating extubation and ICU discharge. So based on this case report evidence, we recommended that you should dialyze when there's refractory hypokalemia, and correction of hypokalemia does not restore the motor function. So in this particular patient, we recommended that as the weakness is worsening, despite appropriate potassium correction, it would be appropriate to consult nephrology for consideration of dialysis. And that's the end of my case report. The N is a little bit anticlimactic in the sense that the patient, despite us recommending dialysis, they decided not to do it, which was fine because the patient ended up doing okay in the end. They had a bit of a longer hospital admission perhaps associated with it, but they did not need intubation, which maybe speaks to how helpful oral mag sulfate is when administered quickly as a possible GI decontamination agent. Again, the problem with GI decontamination is that you never get the satisfaction of saying, well, that definitely prevented a worse outcome here, but perhaps that's what happened in this case. And that's the end of my report. Thanks.
Thanks, Jess. That's a very interesting case. I don't think I've ever treated a barium carbonate overdose in my years at the Poison Center, but good to know that dialysis would be a potential therapy. Any questions or comments from the other guests? Okay. Doesn't look like it, so we'll move on to our final talk from Dr. Carolyn Tan.
Hi, everyone. Is that showing up okay?
Yep.
Perfect. Right. So I'm Carolyn. I'm finishing up geriatric medicine and will be entering my second year of Clin Pharm with Jess and Miriam. Today I'll be presenting a case of rapid onset tardive dyskinesia after a single dose of haloperidol. So the objectives are to discuss an atypical case of TD, to review the spectrum of extrapyramidal syndromes, to summarize previously reported cases of rapid onset TD, and to highlight some special considerations in older adults. So this case is of a 94-year-old retired engineer who was seen in the geriatric medicine clinic in March 2023 for generalized weakness. His medical history included CAD, hypertension, dyslipidemia, bronchiectasis, asthma, suspected indolent lymphoma, and BPH. His only meds were aspirin, rosuvastatin, ramipril, Symbicort, and vitamin D. He was found to have bilateral upper extremity rigidity, rest tremor, bradykinesia, and a shuffling gait with reduced arm swing. So we diagnosed him with Parkinsonism and started him on Sinemet. He responded well, so this was gradually up-titrated to 2 tabs POTID over the next few weeks. In June, he came in with falls and long-acting Sinemet was started. And from September 1st to October 31st, he was admitted with delirium due to urinary retention and got quetiapine 6.25 to 12.5 milligrams PRN for restlessness. He was well up until December 10th when he was started on prednisone and moxie for an asthma and bronchiectasis exacerbation. And 2 days later, he was admitted to Sunnybrook with delirium and agitation and got haloperidol 2 milligrams IM times 1 in a merge. December 15th, he was discharged home with a prescription for PRN quetiapine 12.5. And January 10th, when we saw him in clinic, he had recovered very well, but had what his wife called a persistent lip tremor. So I'm going to play the video, but please let me know if it's not playing properly. So here's a video that was taken at home while he's using the computer. This was a few days after he saw us in clinic. We see involuntary rhythmic orofacial movements at a frequency between 1 and 2 hertz. And the movements were constant, except for when he is eating or talking, and were stable in severity. He didn't notice the movements and remained unbothered by them. So surprised at what we saw, we reviewed his medications again, and the only changes to his outpatient meds were here in blue. He had not used any of the PRN quetiapine, and none of the other medications seemed suspect. So when we examined him, he had ongoing Parkinsonism, but it was improved from the first time that we saw him since he was now on Sinemet. And there were no other abnormal movements aside from this orofacial dyskinesia. We confirmed with the patient, his wife, and Connecting Ontario that there were no prior psychiatric diagnoses or prescriptions. We also reviewed his MARS to add up the doses of PRN antipsychotics he had received while admitted to hospital. So this is the first part of a timeline, and this is a timeline of his drug exposures relative to the onset of those dyskinetic movements and subsequent exams. So during his September admission, which is here, between 65 to 101 days prior to symptom onset, his PRN quetiapine use worked out to 12.5 milligrams daily for 26 out of the 38 days that he was in hospital. There was also 2 milligrams of haloperidol that he received on December 12th, just 3 days prior to the onset of these mouth movements. But that was it for this patient in terms of lifetime antipsychotic exposures. So before we continue with the case, I did want to spend a few moments reviewing the classic extrapyramidal syndromes. So first here we have dystonia, characterized by involuntary sustained muscle contractions like the retrocollis that we see here. Dystonia has both an acute form that begins hours to days after starting or increasing antipsychotics, as well as a tardive form that occurs after weeks to years. And the proposed mechanism is an imbalance of dopaminergic and cholinergic transmission. In terms of treatment, the offending agent should be stopped or at least reduced. And if ongoing therapy is needed, switching to an antipsychotic with lower EPS risk is recommended. And that similarly applies to all the extrapyramidal syndromes. Anticholinergics, benzos, and botulinum toxin injections can also be used. Akathisia also has an acute and tardive form with a similar timeline and is thought to be secondary to D2 antagonism in the mesocortex. It's usually treated with propranolol, but mirtazapine, anticholinergics, and benzos can also be used. NMS, a life-threatening reaction that occurs days to weeks after exposure and characterized by rigidity, altered mental status, hyperthermia, and autonomic dysfunction. It's secondary to D2 antagonism, and in addition to stopping the causative agent, is treated primarily with supportive care, cooling, and benzos. And dantrolene, bromocriptine, or ECT could be trials if there is ongoing symptoms despite the initial treatment. So here we see a left greater than right hand resting tremor of drug-induced Parkinsonism, as well as the oral buccolingual movements and head rocking of tardive dyskinesia. So drug-induced Parkinsonism usually starts after weeks after starting or dose increases in antipsychotics. Symptoms include bradykinesia, rest tremor that's usually symmetric, rigidity, and a shuffling gait. And the mechanism is D2 receptor antagonism in this striatum. If symptoms are ongoing despite reducing the dose or switching agents, then anticholinergics or amantadine may be used. And tardive dyskinesia is characterized by involuntary choreoathetotic movements that are often oral buccolingual. The DSM-4 criteria had specified that to make the TD diagnosis, the patient should have had continuous neuroleptic exposure for more than 3 months, or more than 1 month if over age 60. DSM-5 changed this to neuroleptic exposure for at least a few months, and stated that symptoms may develop after a shorter period of medication use in older adults. The most widely proposed mechanism is upregulation and hypersensitivity of the D2 receptors. And treatment includes VMAT2 inhibitors like tetrabenazine, benzodiazepines, and amantadine. And lastly, Rabbit syndrome, as shown here, is an antipsychotic-induced rhythmic vertical motion of the mouth and lips at 5 Hertz. And as we can see, the name is very fitting. So Rabbit syndrome, like TD, also presents after months to years. And the mechanism is unclear, but may involve dopaminergic and cholinergic imbalance or D2 hypersensitivity, and the treatment is usually anticholinergics. There are several risk factors that are shared between extrapyramidal syndromes, including higher dose, higher potency, faster up titration, and use of first-generation antipsychotics. Being older and female are also risk factors, except for dystonia, for which being younger and male carry higher risk, and NMS, which has no age or gender preference. And other patient-related risk factors include mood disorders, brain structural abnormalities, and prior EPS. Second-generation antipsychotics generally have a lower risk of EPS, but the magnitude of this difference is smaller than we originally thought. For TD, second-generation antipsychotics were initially thought to have a 5-fold lower risk. However, this was likely due to comparisons to high-dose haloperidol, and more recent studies suggest that the difference might actually be less than 2-fold. And the proposed reason for this difference is that second-generation antipsychotics generally have a lower affinity for the D2 receptor and bind for less time. So they stick around just long enough to have antipsychotic effect, but dissociate quickly enough to have a lower risk of motor side effects, kind of like the hit and run that's depicted here. So after reviewing these other extrapyramidal syndromes, we maintained that this patient's movements looked the most like tardive dyskinesia. So I started looking for reported cases of early onset TD and found the following. There was one prospective study done in 1999 following older psychiatry outpatients at regular intervals after starting low-dosed first-generation antipsychotics. They found that 3 out of the 87 antipsychotic naive patients, or 3.4%, had TD at the 1-month follow-up mark. There were 2 cases of TD after a single dose of flupentixol, which is a high-potency first-generation antipsychotic. One occurred 4 days following a 50 milligram IM dose, while the other occurred just 12 hours after a 0.5 milligram oral dose, which would be roughly equivalent to 0.6 milligrams of haloperidol. There was also a case after 1 month of chlorpromazine 300 milligrams PL/BID and 2 cases with risperidone. The first was after 26 days of risperidone 2 milligrams, and the second was just 2 days after risperidone 2 milligrams. However, just 3 weeks prior, this patient had developed laryngospasm after 1 week of risperidone 4 milligrams. In the interim, this patient had also been started on fluoxetine 20 milligrams, which would inhibit risperidone's metabolism primarily through CYP2D6 and therefore increase the concentrations of risperidone. Another case occurred after 1 month of olanzapine 10 daily. And lastly, there was a case of TD after 2 to 3 weeks of quetiapine 150, which was found at Toronto Western. Overall, the course for these cases ranged from fast resolution within hours to 2 weeks of treatment to none at the most recent follow-up. So these early onset cases, in addition to urging caution, I think also highlight that our understanding of the mechanisms of TD is likely incomplete. So here we have a case of tardive dyskinesia, even though there really is nothing tardive about it. For TD, the typical features of this case include the patient's age, which is one of the greatest risk factors for TD, as well as haloperidol, which is a well-established cause of TD with long-term use. He also has Parkinsonism, and dementia with Lewy bodies was on our differential. If this is the underlying diagnosis, this may help explain his reaction, as antipsychotic sensitivity is a hallmark feature of DLB. On the atypical side, we have the duration of his exposures. He had a single dose of haloperidol, yet the problem persists for weeks after the drug is washed out. And the 26 days of low-dose quetiapine is still a very short exposure and would have been a very rare cause of TD. Timing of onset. So 3 days after the dose of haloperidol is an unusually short interval, although in the literature, latencies as short as 12 hours have been reported. Overall, haloperidol was still more likely culprit than quetiapine, since the patient had not taken any quetiapine for 9 weeks before the onset of dyskinesia. We deemed other drug-related and non-drug causes to be unlikely. Levodopa-induced dyskinesia usually occurs a few years after diagnosis and should fluctuate with the timing of Sinemet. Rabbit syndrome has a similar timing to TD, but the mouth movement should be much faster and the tongue should be spared. Withdrawal emergent dyskinesia can look indistinguishable from TD, but should start within a few weeks of stopping a regular course of antipsychotics and last less than 4 to 8 weeks. Mage syndrome is a non-drug cause, but it's an idiopathic dystonia that resembles TD, but usually starts in middle age and includes blepharospasm. Post-stroke involuntary movements are usually accompanied by additional neurologic findings, and asymmetry would be expected. And lastly, there is a spontaneous orofacial dyskinesia, which can look like TD, but is mostly seen in older adults who are edentulous, which she is not, and should also not have prominent tongue protrusion movements. So we elected to monitor this patient's dyskinesia instead of start treatment since he was unbothered by the movements. He continued to do well at home with no change in his Parkinsonism or his levodopa dose. And the patient and his wife, they kindly filmed monthly videos for us to document the evolution of his dyskinesia. And video 5 was actually just taken a couple of weeks ago. So I'm going to quickly show you the progression now. So video 1 is the video that we saw at the start of the presentation. By video 2, we can see a reduction in the frequency and the amplitude of these movements. And the improvement continues in the subsequent videos. In video 5, this is the most recent video where the movements appear to have resolved. So haloperidol was documented as an allergy in his medical record. And we recommended minimizing future antipsychotic exposure given the risk of TD recurrence, as well as the potential for other drug-induced movement disorders. So in summary, despite its usual association with long-term antipsychotic use, tardive dyskinesia can occur after a single dose of antipsychotic medication. Even low-risk second-generation antipsychotics like quetiapine and clozapine still carry a risk of EPS. Older age is the primary risk factor for both the incidence as well as the earlier onset of tardive dyskinesia. Special caution is warranted for patients who have dementia with Lewy bodies, given antipsychotic hypersensitivity in 50%. Treatment of EPS poses additional challenges in older adults, given side effects with the different pharmacologic agents. And lastly, prevention relies on minimizing exposure, and reassessing benefits and risks of ongoing antipsychotic therapy is crucial, especially for older adults who are being treated for behavioral and psychological symptoms of dementia and delirium, conditions where non-pharm strategies are at least equally effective and should be prioritized. Those are my references. I'd just like to thank Dr. Liu, Dr. Yerlink, and Dr. Slow for their input on this case.
Thanks, Carolyn. That's a very interesting case and a very good review of extrapyramidal syndromes. I wonder if there was some component of withdrawal given the long-standing dopaminergic stimulation with the Sinemet, and then the abrupt antagonism by the haloperidol. But the symptoms persisted for so long after the haloperidol that it's hard to implicate a withdrawal syndrome. That should have resolved much faster. Anyway, very interesting. I'll open the floor to any comments or questions from anyone. Okay, well, I think we'll call it to a close then. Thanks everyone for attending. I hope this gave you a bit of a flavor of the types of cases we might be able to help out with on the clinical pharmacology consult service. If you ever have any questions, please don't hesitate to contact either Jessica Lean or myself. And we look forward to working with you all in the future. All right. Thanks everyone. Have a great day.